about diuretics in regard to our fluid and electrolyte. So this will be Unit N. I did talk about diuretics regarding Unit M, so oxygenation in conjunction with some antihypertensive drugs as well. So your diuretic portion of pharmacology is going to be found on Unit M and N. But we'll go ahead and just do another overview in relation to fluid and electrolytes. So diuretics are used for two main purposes, and that's to decrease hypertension, which is lowering blood pressure, and to decrease edema, typically peripheral and pulmonary, in heart failure. So also sometimes in renal or liver disorders. So hypertension is considered an elevated blood pressure greater than 120/80. Diuretics discussed in this chapter are used either alone or in combination to decrease blood pressure and edema. So diuretics are produced to increase urine blood flow, or to diurese, by inhibiting sodium and water reabsorption. So most sodium and water reabsorption occurs in the renal tubular segment. So the descending loop of Henle, the loop of Henle, and the collecting tubule. Diuretics can affect one or more segment of the renal tubule. So every 1.5 hours, the total volume of the body's extracellular fluid goes through the kidneys, or the glomeruli, for cleansing, and this is the first process for urine formation. So small particles like our electrolytes, drugs, glucose, and waste products from our protein metabolism are filtered in our glomeruli. Larger products such as protein and blood are not filtered with normal renal function and remain in circulation. So sodium and water are the largest filtrate substances. Normally, 99% of the filtered sodium that passes through the glomeruli is reabsorbed. 50 to 55% of sodium reabsorption occurs in the proximal tubule, 35 to 40% in the loop of Henle, and 5 to 10% in the distal tubule. Less than 3% occurs in the collecting tubule. So diuretics that act on the tubules closer to the glomeruli have the greatest effect, causing natriuresis. So that's sodium loss. So the closer the diuretic works on the tubule, closer to the glomeruli, the more sodium we waste. So a classic example of an osmotic diuretic is mannitol. So the diuretic effect depends on the drug reaching the kidneys and its concentration in the renal tubule. Diuretics have an antihypertensive effect because they promote sodium and water loss by blocking sodium and chloride reabsorption. These cause a decrease in fluid volume, which in turn lowers blood pressure. So with fluid loss, edema, which is fluid retention in the body, should decrease. But if sodium is retained, water is also retained and blood pressure increases. So many diuretics cause the loss of other electrolytes, including potassium, magnesium, chloride, bicarb. The diuretics that promote potassium are classified as potassium-wasting diuretics, and those that promote potassium retention are called potassium-sparing diuretics. There are 5 categories of diuretics, so thiazide and thiazide-like, loop diuretics, osmotic diuretics, carbon anhydrase inhibitors, and potassium-sparing diuretics. Thiazide, loop, and potassium-sparing are the most commonly prescribed for hypertension and for edema associated with heart failure. Except for those in the potassium-sparing groups, for that specific group, all diuretics are potassium-wasting. Let's talk about thiazide and thiazide-like diuretics. So we kind of just went over this. We went over the types. We went over the purpose. So thiazide and thiazide-like diuretics. So thiazides are primarily used for patients with normal renal function. If the patient has a renal disorder, if their kidney markers are elevated on their lab work, if their creatinine clearance is elevated, then the effect of that thiazide is decreased. So it doesn't work if their kidneys don't work. Thiazides cause a loss of sodium, potassium, and magnesium, but they also promote calcium reabsorption. So hypercalcemia may result if you're taking a thiazide diuretic and can be hazardous to a patient who is digitized or has cancer that causes hypercalcemia. So when we talk about hypercalcemia, go back into our fluid and electrolyte PowerPoint where we talked about those things, how we diagnose hypercalcemia, right? So hydrochlorothiazide is usually used in combination with an ACE inhibitor, beta blocker, or some other type of antihypertensive. So let's see. So a lot of our side effects, again, we talked about these in our antihypertensive power in our antihypertensive pharmacology portion. So these side effects include dizziness, headache, weakness, GI distress, constipation, electrolyte imbalances, because we are shoving out sodium and shoving out potassium. And then a lot of these, so again, we talked about contraindications, renal failure. If their kidneys don't work, this drug does not work effectively. And then drug interactions. Let's talk about our nursing process. So side effects, let me go back up here to drug interactions and side effects. So electrolyte imbalances, hyperglycemia, it can also cause elevated blood glucose, and hyperuricemia, which is an elevated serum uric acid level. Hyperlipidemia. So obviously the most important thing that we should be assessing for is hyperkalemia or hypokalemia. If it's wasting potassium, potassium supplements may be needed with a diuretic that wastes potassium, because it's obviously we need to monitor that sodium the lab work, and make sure that we're not becoming hypokalemic in these patients, because again, that could cause issues with like our cardiac function. So thiazides are contraindicated in renal failure. So symptoms of kidney impairment or shutdown. So if we're looking at our nursing process and our clinical presentation, and our patient's not making urine, if they're having oliguria, which is a clinical, the name or term for a decrease in urine output, and their kidney markers, so their BUN and creatinine, are elevated on their lab work, then those are pretty good indicators that potentially we should not be giving like a diuretic that works, like a thiazide diuretic that works directly on the kidneys. On our nursing process, when we just kind of talked about that. So we obviously want to do our assessment, look for vital signs. We obviously always want to assess for urine output when we're giving diuretics. Look at our kidney value, or our kidney number, so that BUN and that creatinine. We want to look for edema, assess for fluid overload, hypokalemia. And so our goals for these patients is usually that they have decreased blood pressure and decreased peripheral edema. Drug interactions with these, so I keep backing up to this, but drug interactions, so obviously if you're giving this in conjunction with anything else that could potentially affect your potassium levels, we obviously want to monitor those potassium levels very closely. So we talked about how it can induce hypercalcemia, which enhances the action of digoxin. So if you're giving a diuretic with digoxin, it could potentially cause like a lethal cardiac rhythm, and then also it can potentiate the action of lithium, which is usually a mental health drug, so it could cause lithium toxicity. So we have to be very careful with diuretics and what they are prescribed with. So we did talk about the majority of these nursing interventions. So if we're going to suggest, if we're talking about a patient, like when they need to be taking these drugs, obviously we want to take the drug earlier in the day so that we can avoid them having nocturia, which is them peeing at night. So we don't want our patient up peeing all night. We want them to get adequate rest. So we would encourage them to take this drug in the morning. Let's talk about, obviously, usually on patients with diuretic therapy, we want to monitor their daily weight and their urine output. So daily weights would indicate like if they're retaining fluid or if they're effectively passing fluid, and again, your urine output should also be an indicator of if that diuretic is having the desired effect. Also, when we talk about patient movement, we want to instruct them to move positions slowly, because too much of this, if they've kind of had a extra therapeutic effect, or if maybe their dose needs adjusted, could result in some orthostatic hypotension as they're moving positions. So loop diuretics act on the ascending loop of Henle to inhibit chloride transport of sodium into circulation and inhibit reabsorption of sodium. So these cause sodium and water to be lost, as well as potassium, calcium, and magnesium. They can also affect blood glucose and increase uric acid levels. If a thiazide can be given, that's usually our first line. So if a thiazide can be given and alleviate the problem, then we don't want to move on to a loop diuretic. We usually give loop diuretics whenever the thiazide does not work. These also can be given in conjunction with the thiazide if the thiazide is not working. Furosemide is usually administered as an oral dose or IV. And usually these can increase our renal blood flow up to 40%. When a loop diuretic is given, we obviously want to monitor for all the things we talked about with our thiazides. Again, our urine output, moving position slowly, give it in the morning. So again, we also need to monitor those kidney numbers and our potassium levels in our lab work. So the brand name of these is usually furosemide or Lasix. And then torsemide are your two loop diuretics that you would most commonly hear about. That's the majority of information about loop diuretics. And again, your nursing process is very, very similar. We want to monitor daily weights, look at those lab works. And again, when we're giving this, our therapeutic effect of this should be that their edema is reduced and hypertension is reduced. We do this one clinically, and you'll see this in clinical practice as well. When you're giving an IV dose of Lasix, you want to make sure and give it very slowly. It can actually cause some hearing loss if you give it too quickly. So that's one of the side effects of a loop diuretic being given IV and being given too quickly is hearing loss. So that's something that we want to be cognizant of when we give, and usually you push it over about a 5-minute period. So moving on to osmotic diuretics. So osmotic diuretics increase the osmolality or the concentration of and sodium reabsorption in the proximal tubule. So sodium, chloride, potassium, and water are excreted. This group of drugs is used to decrease intracranial pressure, such as cerebral edema, and decrease intraocular pressure. These promote the excretion of toxic substances. So mannitol is usually our most potent osmotic potassium-wasting diuretic, and is frequently used in emergencies where patients have high ICP and high IOP. So when we talk about side effects of this is obviously something we talked about. Mannitol is very, very potent, and usually these patients are in the ICU. They're being monitored very closely for sodium levels. All of their lab work is usually being monitored very closely. And then if we're talking about lowering ICP, something we would always want to consider if we're altering their intracranial pressure is their neurological status. So we would obviously be checking these patients usually hourly, if not more frequently, for changes in neurofunction. So this is also contraindicated in heart disease, heart failure, and renal failure. And these can cause pretty significant fluid and electrolyte imbalances. So when we talked about that, we talked about monitoring that lab work. So also, if we're talking about the solution of mannitol, mannitol can actually crystallize in the vial whenever it gets too cold, and so the vial should be warmed to dissolve the crystals. So we'll talk about carbonic anhydrase inhibitors. So these are like your acetazolamide. These block the action of carbonic anhydrase, which is needed to maintain the body's acid balance base, so that hydrogen and bicarb ion balance. Inhibiting this causes an increase in sodium, potassium, and bicarb excretion. With prolonged use, metabolic acidosis can occur in these patients. So these are usually used to decrease like your intraocular pressure in patients with glaucoma. Those are the side effects of these, again, are confusion, hypotension, GI distress, metabolic acidosis if utilized long term. fluid and electrolyte imbalances, crystal urea, renal calculi, and hemolytic anemia are all things that can occur. And then these are also contraindicated in pregnancy as well. So let's talk about potassium-sparing diuretics. So weaker than thiazide and loop diuretics and are used as mild diuretics or in combination with another diuretic. So these can be used together with like your thiazides or your furosemides. So these promote sodium and water excretion, but also they promote potassium retention. These are usually used to edema from heart failure, cirrhosis of the liver. These help flush out that. We should see a decrease in peripheral edema if we're administering these drugs. These act in the collecting duct of the renal tubule. These drugs interfere with the sodium-potassium pump, and usually that results in sodium being these interfere with the sodium-potassium pump controlled by the hormone aldosterone. So spironolactone is one of our most common potassium-sparing diuretics. Blocks the action of aldosterone and inhibits the sodium-potassium pump. It can be prescribed by cardiologists because of its potassium-retaining effect, so it does not have as much risk whenever we talk about hypokalemia and then the potential for the effect on the heart. So these are usually more effective for your chronic heart failure patients. So we don't want to give, so if we're talking about drug interactions with these, we don't want to give these with spironolactone. Should not be given with your ACE inhibitors or your angiotensin II receptor blockers. So ACE inhibitors and ARBs, because they can also increase your serum potassium levels. So if we're talking about giving this in conjunction with something else, we always want to monitor for those high potassium levels. So hyperkalemia could result if you're giving these with an ACE or an ARB. So that is the main side effect of a potassium-sparing diuretic is hyperkalemia. We also want to tell these people, like whenever we're talking about their diet, to monitor how much potassium they're taking into their diet as well. So nursing process for these is the same. Again, daily weights, I's and O's, look at your vital signs, watch your electrolyte levels in your lab work. Our goals are for decreased blood pressure, decreased edema, and I think, again, always nursing process-wise, this is something we would want to administer in the morning. So let's talk about a quick NCLEX question. So PRBCs, this was actually in relation to blood. So that's not really as applicable to our diuretic presentation. So I actually think that's it for diuretics. So that should complete the pharmacology portions for Unit M and N.